VQ mismatch is a critical concept for the boards, and we've already alluded to it a couple of times during this talk. In this concept, V represents ventilation, and Q represents perfusion. The ideal situation is that ventilation is perfectly matched to perfusion, and thus a VQ ratio of 1. So what happens in the typical person? Well, at rest, lying down, the average person maintains 4 liters of ventilation for about every 5 liters of blood flow, giving an overall VQ ratio of 0.8. However, in the lung of a standing person, there's a variation in the VQ ratio, thanks to gravity. When you're standing, ventilation is much greater than perfusion at the apex of the lung, so you see wasted ventilation. Now, what kind of dead space occurs here? Yes, alveolar dead space. What type of commonly tested infection can occur here in the upper lobes? Tuberculosis. As you can see in this image, there is bilateral upper lobe consolidation due to a primary TB infection of the lung. TB prefers the lung apices because there are oxygen-loving bugs and can thrive in an oxygen-friendly environment. And perfusion is greater than ventilation at the bases of the lung, so you get wasted perfusion. As you can see, perfusion is a function of the interaction between pulmonary artery pressure, pulmonary venous pressure, and alveolar air pressure. It's worth noting, however, that both absolute ventilation and absolute perfusion are greater at the bases of the lung than at the apex. However, gravity increases perfusion more than ventilation. Now let's talk about the extremes of a VQ mismatch. A VQ of 0 represents a complete shunt, in which there is perfusion but no ventilation. So what are some examples of this? Well, you'll see this shunt with status asthmaticus and airway obstruction, like in mucus plugging in cystic fibrosis patients. And in these cases, increasing the fraction of inhaled oxygen does not really improve arterial PO2 because that oxygen will never actually reach the capillaries. Dead space ventilation represents a VQ mismatch approaching infinity. In this instance, there is ventilation but no perfusion. All of this blood doesn't flow through an oxygenated alveolus. So what's a clinical example? Well, a massive pulmonary embolism would be the classic example. In this case, giving the patient 100% oxygen should improve the PO2. Now quickly, what are some cardiac changes you might be able to expect in a patient with a suspected pulmonary embolus? Right heart strain, right axis deviation, and the classic S1Q3T3 lead changes seen on EKG. So far, we've talked quite a bit about the role oxygen has in pulmonary physiology. Just as important, however, are the mechanics of carbon dioxide exchange. From the acid-base physiology material in the first aid renal physiology section, you'll remember how the lungs and kidneys work together to maintain homeostasis in the human body. Carbon dioxide is transported from tissues to the lungs in 3 forms. The majority of carbon dioxide enters the red blood cell and is converted into carbonic acid by carbonic anhydrase. The hydrogen ion dissociates, and what are you left with? Bicarbonate. The remainder is either bound to hemoglobin as carbaminohemoglobin or dissolved CO2. Now let's talk about some key physiologic concepts involving carbon dioxide and oxygen transport. The Haldane effect describes a phenomenon in which carbon dioxide is released from red blood cells. In the lungs, oxygenation of hemoglobin causes dissociation of hydrogen ions, which can then combine with bicarb to form carbonic acid, which then splits into carbon dioxide and water with carbonic anhydrase. So what's the bottom line? Well, this is the opposite of what happens in the peripheral tissue, and basically, the greater presence of oxygen in the pulmonary circulation causes carbon dioxide to be released, and it can subsequently diffuse into the alveoli and be exhaled. As we alluded to earlier, the Bohr effect is when the increased hydrogen ion concentration in the peripheral tissues shifts the oxygen-hemoglobin dissociation curve to the right and favors oxygen unloading to the tissues. Flash quiz. In mucus plugging, you would expect the VQ ratio to be 0. Ventilation approaches 0 since there is no air movement, but perfusion for the most part is unaffected. This topic is high yield because the physiology is so clinically relevant and testable, so be advised this can definitely show up on your exam. Alright, so you probably already know that athletes often train at high altitudes for better speed and endurance. But do you know why? Well, you get increased minute ventilation since there is less oxygen content in the air at higher altitudes. Here you can see the alveolar partial pressure of oxygen is low compared with sea level. Gradually, the body adapts to this altitude by producing more erythropoietin. Put another way, hypoxia is a stimulus for EPO production. Now where is EPO produced? In the kidney. And what does EPO do? It increases the hemoglobin and hematocrit in response to chronic hypoxia. As we mentioned earlier, there is also an increase in 2,3-BPG, which does what? Well, it decreases the affinity of hemoglobin for oxygen by stabilizing the T or taut form of hemoglobin, which promotes unloading of oxygen to the tissues. At the cellular level, over time you see more mitochondria and the concentration of mitochondrial enzymes to improve the efficiency of cellular oxidation. Once you go from acute to chronic hyperventilation, you get a respiratory alkalosis. The body is experiencing a hypoxic state, which causes hyperventilation in an effort to blow off some of this excess CO2. This is countered by an increase in renal excretion of bicarb. As you remember from the first aid renal farm section, we give acetazolamide to treat acute mountain sickness by forcing the kidneys to waste bicarb. From a cardiovascular standpoint, chronic hypoxia leads to pulmonary vasoconstriction, and over the long run this can cause pulmonary hypertension and right ventricular hypertrophy. Finally, I've mostly talked about chronic changes in the lungs, so I'll just mention that in addition to acute mountain sickness, a rapid increase in altitude can lead to pulmonary and cerebral edema, also known as high-altitude pulmonary or high-altitude cerebral edema. This is thought to be secondary to an increased arterial and capillary pressure and increased capillary permeability. It's a much feared condition of mountain climbers, and it's the reason why people who are attempting Mount Everest stay at base camp for a few weeks at 17,000 feet before summiting to acclimate before a rapid ascent. So let's wrap up respiratory physiology with exercise. What happens when you exercise? Well, obviously there's an increased oxygen consumption and increased carbon dioxide production. Of course, the respiratory rate goes up to meet this increased oxygen demand and carbon dioxide production. And more specifically, there's an increase in both ventilation and perfusion. The VQ ratio from the apex to the bases of the lungs will become more uniform. So exercise causes vasodilation of the apical capillaries. So the pulmonary blood flow you see occurring in zone 3 occurs in other zones as well, despite gravity's usual effects. As cardiac output increases, there's a proportional increase in pulmonary blood to support more efficient exchange of oxygen and carbon dioxide. Interestingly, there's no change in PaO2 or PaCO2 because of efficient gas exchange, but there is an increase in venous carbon dioxide content. Finally, there's a decrease in pH because of lactic acid production. So to recap, what does this do to the oxygen dissociation curve? Well, it shifts it to the right, remember? This allows hemoglobin to unload the oxygen in the tissues where it's needed the most. Finally, the exercise physiology principles that we've just covered can also be extrapolated to other situations in which the body is subjected to acute stress, such as during illness or after surgery. A physiologist divides the lung into 3 zones, with the apex being zone 1, the middle region being zone 2, and the base being zone 3. In an experiment, the physiologist applies a small amount of positive pressure ventilation while studying blood flow in different lung zones. Which of the following will be noted in this experiment assuming the subject is standing? The answer is B. Blood flow will be reduced in zone 1. If the subject is standing, a VQ mismatch will always exist. Arterial blood flow will be the greatest near zone 3, and blood flow will be the least near zone 1. Enhancing ventilation via positive pressure ventilation will increase the VQ ratio further. Positive pressure ventilation increases alveolar pressures even further, causing compression of the arterioles. This compression then leads to reduced blood flow, especially in zone 1. Alright guys, good job! Take a minute to review some of these things we talked about in this video. It will surely be tested in your exam and you'll want to be prepared for it. I'll see you next time.